Hello and welcome to this module of the online C3IFT course. This module is going to be all about managing your ventilator and that patient that's on the ventilator. Module 3, Ventilator Management. Taking a vent patient is very scary to some people, especially if you don't do it all the time. And it's one of the most dangerous calls we will run because that patient is very dependent on your skill as a provider and your knowledge of how to work that ventilator so they can survive to get to the next facility. So what is mechanical ventilation? Believe it or not, it's actually completely contrary to normal physiologic ventilation. Normal physiologic ventilation involves moving up and down the diaphragm, relaxing and contracting. In this case, the diaphragm isn't working at all. Air is going to be forced into the lungs via the ventilator. Your patient's either sedated or sedated and paralyzed, so that diaphragm's out of the picture. All the air has to be taken into the lungs and back out by the ventilator. It's a very stressful situation for some people, especially if you don't transport vent patients a lot, and it can be a very dangerous situation. The patient is completely dependent on your skill as a provider and your ability to manage that ventilator and any problems that might arise during transport. We're going to start with an anatomy review. First of all, during inhalation, the diaphragm contracts, the chest expands, and air is sucked in through the oral or nasal pharynx. During exhalation, the diaphragm relaxes, moves back up into the chest cavity, the chest contracts, and air is forced back out through the same holes. If you remember just a minute ago, I said that during mechanical ventilation, the diaphragm is completely taken out of the equation because your patient's either sedated or paralyzed or both. So all this process must be done via pressure. If we take a good look here, all of these structures are important to managing your vent patient. First and most obvious, the trachea, because that's where your endotracheal tube is going to go. Normally, you want your endotracheal tube to sit 2 to 3 centimeters above the carina, or that bifurcation in the trachea there. And that'll be done with chest x-ray. When you go to take a vent patient, you should take a look at the x-ray report after they've done the intubation and make sure that it says, when it's read by the radiologist, that the ET tube is 2 to 3 centimeters above the carina. Any lower than that, you run the risk of getting a right main stem and only ventilating the right lung. Other things that are important, your alveoli, right? All this is dead space. The only thing doing gas exchange and actually doing the body any good is the alveolar sac. We have to keep that in mind when we're ventilating the patient mechanically. We have to take into account the dead space. If you take into account the oral pharynx, the nasal pharynx, the entire trachea and the bronchioles, dead space is about 2 milliliters per kilogram of ideal body weight. We're going to talk about ideal body weight later, but it's important now to know that there is a lot of dead space to overcome when you're ventilating your patient. So we'll keep that in mind as we move through this. End-tidal CO2, probably the most important tool we have for managing that ventilator patient. Because if something happens with the circuit, with the ventilator, with the patient, we'll be able to see it in real time on our end-tidal CO2. Here's a quick review of different end-tidal waveforms. Pay close attention to the decreasing end-tidal CO2 waveform that you see here and all of the things that may cause it. Right? These are all things that can happen with a ventilated patient. Again here, sudden loss of waveform, that's the big one that we're worried about, because if that tube becomes dislodged, the vent circuit becomes detached, you're going to see this, and we're going to know instantaneously that we have a problem with our ventilator. That is why every patient that you take on a ventilator must have end-tidal CO2. If you remember before, a few modules ago, I talked about how C3IFT is changing. We know that if you look on the state website and you look on the required equipment list, end-tidal CO2 is not required but optional for transport ambulances in West Virginia. When the new protocols come out for C3IFT, if you're going to be doing C3IFT, you're going to have end-tidal CO2 capability. Terms to know. There's a lot of them when it comes to talking about ventilator management, so bear with me for a few minutes. We're going to start with tidal volume. There's been a lot of changes in tidal volume recently in ventilator management, talking about lung protective strategies for tidal volume. We're going to get into that later. But tidal volume, importantly, for you to know right now, is the amount of air inhaled during a breath. Tidal volume is a function of your ideal body weight, which we're going to talk about later. Also with tidal volume comes exhaled tidal volume. You should know that when you're putting tidal volume in, you want it to come back out. And most ventilators are going to express that to you. And it's usually expressed like this: a V, a T, both uppercase, and then a little E. And that reading is your exhaled tidal volume as your readings come across your ventilator. So, important thing to know. Respiratory rate is your number of breaths per minute. Your minute volume, that's your tidal volume times your respiratory rate, the amount of volume you're taking in every minute. Also an important setting. Dead space. We talked about dead space a few slides ago. That's the place where no gas exchange is happening. That's the only place that gas exchange occurs is in the alveolar. Everything else is just dead space. So we have to calculate that when we're thinking about ventilating a patient. Mean airway pressure. That is the average pressure that it's taking to deliver a breath. Your ventilator is going to calculate that for you. Peak inspiratory pressure. Maximum pressure to give a breath. Plateau pressure. That's an important one because that's the pressure at your alveolar bed where the gas exchange is actually taking place. It's important to get a plateau pressure on your patient to make sure you're not overventilating or underventilating your patient. Positive end expiratory pressure. This is PEEP. We know about PEEP from CPAP when we talked about CPAP in paramedic class. It's the pressure that's left after you exhale. That PEEP keeps your alveolar sacs open. It's important in patients with ventilatory issues to have good, solid PEEP so their alveolar aren't collapsing down every breath, and it makes it just that much harder to get them inflated again on the next breath. Types of ventilators. There are simple ventilators like this one, otherwise known as a death box. Basically, you set your respiratory rate and your tidal volume, and you pick adult or child inspiratory time, and it ventilates the patient like that on 100% oxygen. This is really bad for patients. It's not a whole lot better than bagging. The only thing it gives you is consistency. So if you have that, try and talk your company into buying a complex ventilator. They're expensive, but you really only need one. So this is an example of a good complex ventilator that's really easy to use and friendly for the transport environment. It's not that big, it's not that heavy, and it works really well. It's LTV 1200 by Pulmonx. You can pick them up used for a reasonable price. So we shouldn't be using simple ventilators like this anymore. We want ventilators that do stuff like PEEP and FiO2, all that stuff we're going to learn about later. You want that stuff for your patient. This doesn't do any of that. So you want a good ventilator for your service. There are two types of ventilations we're going to talk about, and then there are many different modes of ventilation. The types of ventilation are pressure or volume, and that type of ventilation must match the patient condition. In pressure ventilation, breaths are given until a set pressure is reached with no real regard to tidal volume. This is most commonly used in pediatric patients or patients with poor lung compliance. Volume ventilation, breaths are given to a set tidal volume. Sometimes pressure can be taken into account with pressure-regulated volume control ventilation. We'll talk about that when we get into modes of ventilation, but volume is by far the most common type of ventilatory mode for your patient. Like I said, breaths are going to be given to a set tidal volume based on the patient's size, and based on their size, you can calculate a really good physiologic tidal volume for patients. That's why it's the most common way to ventilate a patient. So the types of ventilation figure out how the breath is going to be given, and then the mode of ventilation figures out in what manner the respiratory rate is going to be dependent on and things like that. So there's a couple different modes. Assist control, synchronized intermittent mandatory ventilation, PRVC or pressure regulated volume control, or NPPV or non-invasive positive pressure ventilation like BiPAP. We'll start with assist control because it's the simplest. There's a set number of breaths given to a set tidal volume or pressure, depending on what type of ventilation you have picked. It allows for patient input, but here's the problem with assist control. If the patient triggers a breath on assist control, they're going to get the full tidal volume, whatever you have set. This becomes a problem if they start triggering a bunch of breaths. You get breath stacking. It's a good way to pop a lung. Assist control is fine for patients that have no input into the ventilator. Either their diaphragm is paralyzed in such a manner they can't move it, or they're chemically paralyzed because you or the hospital has given them a paralytic drug. So if they don't have any control or input over what the vent is doing, assist control is just fine. SIMV, or synchronized intermittent mandatory ventilation, is a little bit better mode of ventilation because it allows for patient input. There are set breaths at a set tidal volume, but it provides some pressure support if the patient inhales, only to overcome the dead space. So if I'm the patient and I'm sedated, but I still have a little bit of spontaneous respiratory effort, the ventilator is going to give me 14 breaths a minute at 400 milliliters. But if I initiate a breath, it's just going to give me a little bit of pressure support to overcome the dead space in the tube and stuff, and then I'll be able to pull whatever tidal volume that I want to pull for my comfort if I'm the patient. So it's great for patients that have spontaneous respiratory effort. I think we're going to see this used a lot more now that evidence-based medicine suggests that long-term paralytics are bad for patients. So if your patient's not paralyzed and they have the ability, or the ability in the future, maybe if the sedation starts to wear off, to initiate breaths, you really want to have them in SIMV. PRVC, or pressure regulated volume control, is an awesome mode of ventilation. The problem is that most transport ventilators that I've seen don't have a PRVC setting. So really what it is your synchronized intermittent mandatory ventilation, or your SIMV. It does everything there that SIMV does, but it has a max pressure setting. So if for whatever reason the patient would cough or start to get agitated, whatever, you're not going to deliver over a set maximum pressure. It's the safest, most common mode of ventilation now. And when you go into hospitals, you'll see most of the hospital ventilators, the patient is on PRVC. And when you think, well, I can't take the patient because my ventilator doesn't have PRVC, it's fine to take it on SIMV because most transport ventilators will have an alarm if you go over a set pressure. So while it may not terminate that breath like PRVC does, it'll set off an alarm so you can know something's up. Hey, the patient's waking up. Hey, we're giving too much tidal volume. Whatever, our pressure alarm is going off, so we know to change something. If you took a ventilator class 3 or 4 years ago, they would tell you that tidal volume is 7 to 10 milliliters per kilogram of ideal body weight. We're going to cover most of the math behind this later, but the point is it's low. It's a lot lower than what we thought it was. It's a lot lower than what we thought it was supposed to be. 6 milliliters per kilogram of ideal body weight is plenty of tidal volume for just about everybody. And, people don't have bigger lungs because they weigh more. They have bigger lungs because they're taller. So if you go to the hospital and you see a nice little old lady that's 4'2" with 500 milliliters of tidal volume on her vent settings, she's getting way too much. It's all about how tall you are. So it's important to calculate your tidal volume based on ideal body weight. Respiratory rate. If you think back to paramedic class, we taught you that respiratory rate is the most overlooked vital sign. So taking a vent patient is kind of cool in the fact that we can figure out whatever respiratory rate we want. But it has to be a normal physiological respiratory rate. We don't want to give it too high, we don't want to give it too low, although there are instances where you're going to raise your respiratory rate somewhat over normal. But your respiratory rate is calculated based on ideal body weight. It's your minute volume divided by your tidal volume that'll give you a respiratory rate. And your minute volume should be your ideal body weight times 120, and that's going to give you a good minute volume. Minute volume is probably going to come out around 6,000 or 7,000 milliliters a minute. And then you divide that out to get your respiratory rate. Like we said before, PEEP is positive end expiratory pressure, basically the pressure left in the lungs after exhalation is complete. Normal physiologic PEEP is 5. People with vent problems, like they're having lung issues, ARDS, CHF, whatever, you may see the PEEP go up to about 10. I really wouldn't feel comfortable taking anybody that has a PEEP over 10 in the C3 environment, because when you get into really high PEEPs, a whole bunch of other stuff starts to happen. You have to change a bunch of other settings. It would just be really hard for somebody that didn't have a really great understanding of all that a ventilator can do to manage a patient with really high PEEP. So most of the time your patient is going to have a PEEP of 5, maybe 6 or 7 if they have a lung problem. Be wary of a patient that you go to and they have a PEEP of 20 or 15 even. FiO2 is your fraction of inspired oxygen. That can change with altitude and it becomes a very complicated math problem. At the simplest form, it's 21 to 100%, and that's the percentage of oxygen that the patient's getting with each breath. If you have them on room air at this normal altitude, it would be 21%. You can change it all the way up to 100% on most ventilators. Some of the old auto vents or death boxes, like I called them, it was either 50 or 100. There was really nowhere in between. The lowest you could go was 50, or you could turn it up to 100. There was nowhere in between. You should titrate your FiO2 to an oxygen saturation of 94 to 100%. A lot of times we go to these small hospitals and they're on 100% FiO2. That can be bad for patients in the long term. It can actually cause atelectasis or breakdown of the alveolar membrane in the lungs if they get too much oxygen for a really long period of time. It can also cause ventilator dependence. So we want to wean that down to the neighborhood of 94 to 99% finger pulse ox. If you're getting an O2 sat of 96%, then that's great. Your FiO2 is in the right spot. Your alarms are going to be dependent on what kind of ventilator you have. When you go to work at an agency, you really need to get familiar or talk with somebody who's really familiar with the ventilator that you have and know the alarms and how to fix them. Most alarms are really easily fixed if you understand what's causing it. If you don't understand what's causing it, that ventilator can sit there and beep at you the entire transport. And it's really annoying. It can make you uncomfortable. It can also make you look kind of dumb when you roll into the hospital and your ventilator is singing like a choir. So whenever you go to work, make sure you get familiar with the ventilator that you have somebody go over it with you so you know what the alarms are and what to do to fix them. When you go through your basic setup of the vent at the bedside when you get to the hospital, you're going to want to look at the hospital settings and see if they make sense and see if they're working for the patient. Most of the time, they're going to make sense and they're going to be working just fine. Every once in a while, you'll go to the hospital, you'll have a 4'2" nice old lady who is on 500 of tidal volume. And that just doesn't make sense. It's way too much, way more than 6 milliliters per kilogram of her ideal body weight. So you're going to have to talk with the doctor and the respiratory therapist if changes are needed. At the C3 level, you can't make changes to the ventilator settings unless the doctor okays it. So you want to work out the math, which you're going to learn about here in a little bit, and talk it over with the doctor, make sure they're okay with it, then make your changes. It also never hurts to ask for a blood gas. In this class, we're going to teach you how to interpret a blood gas and how to make sure that that ventilator is doing the right thing for that patient at the cellular level. That's really, the blood gas is really your window into what the patient's doing at the cellular level. So it's very good to look at that before you leave. Your setup should be done at the bedside. Even if you copy the patient's settings exactly into your ventilator is not the same ventilator that the patient was on. Things can go wrong. You want to make sure you get a good baseline, including the end tidal CO2 of what they're doing on the hospital's ventilator. If they're doing well, then that's great. When we put them on our ventilator, we want to make sure they're still doing well. When you change them over to your ventilator, make sure that the vitals stay within the same range. If it happens to not work, place the patient back on the hospital ventilator. That's why we do it at the bedside, because if our stuff fails or it doesn't work or the patient doesn't like it, we can put them right back on the hospital ventilator and they can go back to ventilating the way they were, which in theory was keeping that patient in a good stable state. You also want to make sure you have an adequate oxygen source. On 100% FiO2, every bit of that breath is eating up your oxygen. So keep that in mind as you're thinking about these transports. Even before you leave the station, make sure you have a good main that's full of oxygen so you can take that transport without running out of it. Adequate sedation is really important for your ventilated patient. Endotracheal tubes are painful. It hurts when they go in. It hurts when they're in there. That comes from patients that have not been adequately sedated. And mechanical ventilation is uncomfortable. How would you like somebody forcing air down into your lungs and expanding your chest? It would not be real comfortable. So you want to keep the patient comfortable. Getting a good physiologic tidal volume and respiratory rate is the first step to that. Once you have that complete, the patient will require minimal sedation. Research and best practice has proven that. When we're talking about sedation, fentanyl and Versed is by far the most common form of sedation for ventilated patients. When you combine these two together, their effects are increased. Fentanyl has the analgesic effects, Versed has the sedative effects, and the amnestic effects. When you combine them together, they both become more potent. So it's a great combination to do fentanyl followed by Versed, flush that in, your patient becomes nice and sedated. As protocols are changing, we're having more options for sedation. Ketamine is now approved in West Virginia for the 4000 series, and once it comes out, these new updates come out, we'll be able to do it as a C3 medic for sedation. Ativan is also a good option. We don't carry it on the ambulance anymore, but you can still get it from the hospital. Ativan is great when your patient's blood pressure is not doing so hot. Large doses of Versed can have hypotensive effects. So if your patient's blood pressure is borderline, or they're on a vasopressor drug to try and keep their blood pressure up, it's okay to ask for Ativan instead of Versed. And everybody's favorite, Diprivan or Propofol, the white stuff that hangs in the glass bottle, hospitals seem to love that stuff. They put everybody on it. Right after they intubate them, they get on a Propofol drip, and that's how they stay till we come to take them. Diprivan is not approved right now for C3 medics to transport. So if they're on a Diprivan or Propofol drip, that's going to have to be discontinued before you can take them out of the hospital. New research and evidence-based practice suggests that long-term paralytics are actually really bad for patient outcomes. They can become dependent on the ventilator, very hard to wean them off of the ventilator, so we're trying not to give paralytics to people for the long term. The short term is okay as they're inducted into RSI, so they give the sedative, they give the paralytic, which is most of the time succinylcholine, very short acting, wears off, then we just keep them sedated. Vecuronium is the approved paralytic for the C3 realm. Again, we're trying not to give that a whole bunch because it's not good for the patient. There's a lot of consequences beyond the immediate that you'll see, which what you'll see is your patient paralyzed for 45 minutes and not be able to move. But there's consequences beyond that in their long-term ICU care. So we're trying to get away from that. If you do the right vent settings and the right sedation, most patients won't require paralytics. If they're still absolutely freaking out, bucking the ventilator, it's okay to give it, but we're trying not to. Rocuronium is the other long-term paralytic, not approved for use by C3 paramedics. What we were having to do for a while is have the hospital give it right before we went out the door because there was a shortage of VEC and we couldn't get it. So the hospital was having to push it right before we left, and as long as you had less than a 45-minute transport, it was going to last for you. This is probably the most important slide in the entire class. If you've paralyzed your patient, you must administer adequate sedation. There's no ifs, ands, or buts about it. If they are paralyzed, it's going to do nothing to keep them sedated. You have to administer sedative meds. And let's think about the duration. We said in the last slide, if you dose vecuronium appropriately, your patient's going to be paralyzed for about 45 minutes. How long does Versed last? That lasts about 15 to 20 minutes. So you need 2 doses of Versed and fentanyl, hopefully, with your 1 dose of vecuronium. It's really important to keep the patient sedated. They can wake up underneath that paralytic and be awake and paralyzed. It's a really bad feeling. You can look it up on YouTube and see horror stories of people being paralyzed but not sedated. It's just bad. It's not good. People have been sued over it. So please, if your patient has been paralyzed, make sure you're adequately sedating them so they don't wake up and realize they're paralyzed. That would not be fun. I don't want to do it. You wouldn't want to do it. So don't do it to your patients. And I get asked this question a lot. Bagging is easier. Why don't we just do that? We have to take a third person anyway. Why don't we just bag the patient the whole way to the hospital? It's really, really bad for the patient. It's unbelievably bad for the patient. The tidal volume of an average adult, 300 to 500 milliliters. Your adult BVM has 1500 milliliters with every squeeze. So you could be giving them up to 3 times as much as their normal tidal volume. And are you a machine? Are you going to sit there and count to 6 and squeeze and do that with the same tidal volume, so the same volume of squeeze every time? It's just not going to happen. Even the most focused OCD concentrated person is not going to be able to sit there and give me a consistent rate and a consistent tidal volume for the whole trip to Ruby. It's just not happening. And is the patient getting any PEEP? Unless your bag valve mask is a fancy one and has a built-in PEEP valve, they're not getting any PEEP. So your alveoli are completely collapsing down at the end of every breath. Long-term bagging has all of the following effects: pneumothorax, respiratory acidosis or alkalosis, hypoxia, patient discomfort, decreased lung compliance, increased interthoracic pressure, cardiac compromise, hypotension, ventilator dependence. I can go on and on and on. The moral of the story is bagging your patient is not easier and it's not good for the patient, so don't do it. Reviewing for this module. Absolutely every patient that you put on the ventilator must have end-tidal CO2 monitoring. You need to be looking at that waveform, monitoring the number, making sure you're doing what's right for the patient, and making sure that your vent doesn't just spontaneously stop working and the patient doesn't get to breathe. That patient is dependent on your skills and your ventilator. So everything you can do to monitor how that patient's doing, you should be doing it, including end-tidal CO2. Make sure you're comfortable before you leave the hospital. This goes back to what we talked about before when we were talking about doctors dumping train wrecks on you. Sick people go to small hospitals all the time. Some people just don't ventilate well. Some people you won't have the knowledge without taking a week-long class on ventilator management to be able to fix them enough to keep them stable to take them to the other hospital. So be comfortable before you leave. Set the ventilator up at the bedside and make sure the patient's going to ventilate well before you leave the hospital. Once you leave, you're on your own, whether you have to bag them the whole way or fight your ventilator or whatever, but you're on your own. So make sure you're comfortable before you leave. Bagging the patient for any length of time is not acceptable patient care. It's not the standard and it's bad. Don't do it. If your settings are correct and your patient has a physiologic normal tidal volume, normal respiratory rate, normal minute volume, they're going to require less sedation and they will be way more comfortable for your transport. So make sure your settings are correct. Once your settings are correct, they're going to require very minimal sedation. You shouldn't have to paralyze them, and your transport's going to go just fine. If you remember these things and you practice with the ventilator, you're going to be comfortable with vent transports. We're going to do a lot of setting up the vent and playing with it during the hands-on portion of the class. So hopefully this gets you a good broad understanding, and then we'll fine-tune your ventilator skills once we get you in here for the hands-on.